are the core elements, which are best practice guidance document created by CDC. And we're going to talk just at a very basic level about the regulations that govern stewardship programs in long-term care facilities. Our learning objectives specifically are to review current evidence-based guidance for implementing and maintaining an antibiotic stewardship program within a nursing home. Secondly, as I stated, we'll discuss the federal regulations related to antibiotic stewardship programs in nursing homes. First off, let's define what is antimicrobial stewardship exactly. Antimicrobial stewardship at its most basic level is to only use antibiotics when they are truly needed. The more specific definition from CDC is the effort to measure and improve antibiotic prescribing by clinicians and the effort to improve antibiotic use by residents. Why is this so important? First off, stewardship programs are a regulatory requirement, which we'll cover that here in an upcoming slide. Perhaps equally important, however, stewardship programs promote resident and patient safety. Up to 3/4 of all antibiotics prescribed within a nursing home setting are prescribed incorrectly. Incorrectly can mean incorrect dose, or it is an unnecessary antibiotic. 20% of those prescribed an antibiotic will have an adverse drug reaction. One thing that has really shocked me in my career as a pharmacist is that antibiotics have actually caused some of the worst side effects that I have ever seen. That's not something I ever thought that I would say. After all, we tend to think about opioids as being the ultimate boogeyman when it comes to medications, and they are very serious, but antibiotics can cause some pretty serious harms as well, and that's why we want to only use them when they are truly needed. Stewardship programs promote efficiency. They improve quality, ultimately. Fewer urinalyses performed free up more time for your nursing staff. Less MDROs means less need for enhanced barrier precautions. Next question you may be asking is, how do I build this? Fortunately for us, there is that best practice guidance document that I talked about earlier, the core elements of antibiotic stewardship for nursing homes, written by CDC. These provide practical guidance and implementation strategies for nursing homes. These are the 7 core elements here. I like to think of them as the 7 pillars that hold up the whole structure, or the whole house, if you will, of antibiotic stewardship program. These are each buckets that contain practical strategies, and we'll walk through each of these. There's leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. Leadership commitment strategies including stewardship-related duties and position descriptions. Medical director, clinical nurse leads, consultant pharmacists, you could technically put it in all job descriptions, perhaps frontline nursing as well. This just helps to set expectations from the beginning of how this person will participate and support your stewardship program. Writing statements in support of improving antibiotic use to be shared with staff, residents, and families. These statements can be signed by your leadership. Leadership can include the medical director, the chief nursing officer, perhaps an administrator as well. Additionally, another way to display leadership commitment is to communicate facility expectations of antibiotic use, communicating them widely through perhaps a newsletter or some sort of signed statement, again, similar to that letter. Accountability bucket speaks directly to the leads of the stewardship program. Per the CDC core elements, the recommended leadership roles are the medical director, the director of nursing, and the pharmacist. On the right-hand side is a great reference in terms of if you ever want to write into people's job descriptions their specific stewardship duties. That's a document from CDC that outlines each of their responsibilities that can be followed. Drug expertise speaks specifically to how the consultant pharmacist is going to support the nursing home stewardship program. Ideally, if possible, it's good to work with a consultant pharmacist who has received specialized infectious diseases or stewardship training. Pharmacists can provide feedback to prescribers on antibiotic choices. We can make recommendations on good antibiotic choices. We can assist with writing local guidelines, provide education, share evidence to promote best practices, and we can also review culture data as well. The action bucket has strategies such as writing policies to support optimal antibiotic use. For example, maybe a timeout policy, if that is necessary in your facility, might be a good way to meet that action piece. Creating infection and syndrome-specific interventions to improve antibiotic use is a very common action taken by a lot of nursing homes, and that looks like your SBAR and also timeout, actually, in some cases. This might also look like putting the Loeb criteria into action as well. Pharmacist interventions can also be in action depending upon the specific type of intervention used. Perhaps if they help you with timeout, or if they help audit specific guidelines, institution-specific guidelines, that can be considered an action as well. For tracking and reporting, let's kind of take each of these terms separately. Tracking means, per the core elements, to monitor at least one process measure of antibiotic use and at least one outcome measure of antibiotic use in your facility. Reporting means to provide regular feedback on antibiotic use and resistance to prescribing clinicians, nursing staff, and other relevant staff. This can look like maybe a report at your monthly or quarterly or however often you meet QAPI committee, for example. That's probably one of the more common ways that nursing homes will share out their data. I will emphasize it's always, always, always important to share the data for stewardship work or any quality improvement work that you do in order for folks to see and celebrate the great work you're doing, or to give them opportunities to provide some support if you need that. Now, I introduced the terms process and outcome measure. So let's now define that a little more. Process measures how and why antibiotics are prescribed. Example of how you would measure this process includes chart reviews to determine if facility policy was followed. Likely a lot of you do this already with perhaps the SBAR, McGeer criteria, or even Loeb criteria. It's a very familiar one. Another term that wasn't quite introduced here on these definitions, but is also relevant, is antibiotic use measures. What are we tracking? How many and how often? These are most commonly tracked as antibiotic starts. This is a fairly simple metric. If the antibiotic was started, that's your part of your count for the month. Another way to track it is days of therapy. Days of therapy refers to how many days of therapy of antibiotic that the particular resident received. This is a little bit more mathematically complex if you're computing by hand. If you have an EHR that computes this for you, that's fabulous. Days of therapy is a metric I personally prefer because it captures a wider breadth of interventions. For example, if you do a timeout, your antibiotic start data is not going to capture that you did that timeout, versus days of therapy will capture that because you're going to notice a decline in your days of therapy. But again, this is whatever antibiotic use measure works for your facility is the right one for you. Outcome measures are adverse outcomes and costs. Big one that nursing homes like to measure is C. difficile infections. You may also be looking at antibiotic-resistant organisms. Adverse drug events can be a little bit tougher to track, but nonetheless, that is considered an outcome measure. The education core element bucket recommends education and feedback to providers on prescribing practices. This can look like flyers, newsletters, pocket guides. There's a wide variety of ways to educate. Education for residents and families is also very, very important. This can look like putting perhaps an education and orientation packet so that they're informed right when they come in the door that this is the facility's stance, if you will, on UTI antibiotics, for example. Tables with brochures at the front entrance might be a good way to kind of introduce that education to them. And then possibly the more common one is handing them a brochure when an antibiotic may or may not be a part of that resident's care plan. Now that we've talked about the core elements, we've talked about that structure, let's talk now about the regulations. The most well-known regulation is the infection control regulation. The facility must establish an infection prevention and control program that must include, at a minimum, the following elements: a program that includes antibiotic use protocols and a system to monitor antibiotic use. There are some F-tags associated with this regulation if it is not adhered to, and F881 is probably the more well-known one. An F881 tag is obtained when there's demonstrated failure to develop and implement protocols to address the treatment of infections by ensuring that residents who require antibiotics are prescribed the appropriate ones. A failure to develop and implement antibiotic use protocols that address unnecessary or inappropriate antibiotic use, or a failure to develop, promote, and implement a facility-wide system to monitor those antibiotics. Our next reg is more applicable to the pharmacist's role. Drug regimen review. The drug regimen of each resident must be reviewed at least once a month by a licensed pharmacist. The pharmacist must report any irregularities to the attending physician, the facility's medical director, and director of nursing, and these must be acted upon. Kind of continuing on from that drug regimen review, unnecessary drugs are actually defined as antibiotics, and so antibiotics are included in that monthly drug regimen review. And this reg specifically calls out that each resident's regimen must be free from unnecessary drugs. There is additionally another regulation as well that may be applicable to stewardship programs, and that's related to planning and implementing care. The resident has the right to be informed of and participate in his or her treatment, including the right to be fully informed in language that he or she can understand, of the care to be furnished, of the risks and benefits of treatment and alternatives, and to choose the option that he or she prefers. The applicable F tags associated with drug regimen review are the top two ones, and the third one down at the bottom is applicable to that, planning and implementing care. F756 is for concerns related to the failure of the pharmacist to review and report any unnecessary antibiotic irregularity. F757 is for concerns related to unnecessary antibiotic use, specifically inadequate indications or for use or monitoring, excessive dose and duration, and adverse consequences. F552 is related to concerns related to the right to be fully informed in advance about care or treatment. And with that wraps up, that's going to wrap up the didactic portion of our presentation today. I also want to take just a quick moment to highlight that we've talked a little bit about pharmacists' role today in stewardship programs. If you have a consultant pharmacist who is interested in learning more and being more involved in stewardship, this is an opportunity for them. And I would encourage sharing that opportunity with the facility's consultant pharmacist. And as I stated before, this QR code, do not worry about it. This is for our online viewers. If you are viewing this online, please do scan this code. We want to make sure that we count your attendance towards your certificate.
All right, I'm going to stop the recording